Hello, my name is Gemma Stratton, and I am a senior at James Madison University studying social work. I am currently doing my 472-hour BSW practicum at Western State Hospital, which is a psychiatric state hospital in Stanton, Virginia. This is a video version of a presentation that I gave as a part of that practicum, and I delivered an in-service presentation for the Department of Social Work, but I wanted to have it available online as well. My presentation is focused on how the motherhood experience may intersect with the treatment implications of female patients with schizophrenia. Through my time at Western State, I have had opportunities to notice how women with schizophrenia are impacted by motherhood and past birth experiences, as well as their relationships with their children. And I thought it was something really important that we start having discussions about in social work. Even though I'm focusing on schizophrenia, this can be applicable to many other diagnoses, especially if they involve recurrent delusions or hallucinations, and because those patients can be especially vulnerable to being impacted by previous birth trauma or motherhood experiences. So here is just a quick overview of what I'm going to talk about today. The presentation is relatively quick, about 30 minutes. And I just like to highlight what we can do as social workers to make the treatment for these patients go smoother, and highlight some things about their social history that we might not be currently gathering information on working with these patients. When I did this presentation, I did an exercise for the social workers in the room to see how common the situation is when you have a patient who's very, very impacted by an experience of motherhood. Since this is virtual, feel free to just think whether any of these things have applied to you in your practice or might apply to future practice. So have you ever had a patient who has had a child under the age of 18 out in the community while they have been hospitalized, lost custody of their children in the past due to their mental illness, reported having more children than they actually have, believed they were pregnant when they were not, or believed that their child or children had been stolen, or even accused a staff member of stealing them? These are some of the many different situations that professionals can find themselves in when working in or with a population with psychiatric illness. These are very common experiences in these environments, especially with women, although sometimes it can occur in men and male populations as well. But these are just some examples of situations where you might need to use some of this information in order to provide the best treatment and guidance for your patient. So first, I want to just talk about what is maternal mental health and what I really mean when I'm going to talk about that today. So maternal mental health and maternal mental illness can be used interchangeably in a lot of dialogue and conversations. I really wanted to emphasize the difference between them for the purpose of this presentation and the purpose of the discussion that I'm trying to have. So maternal mental illness is something that occurs during pregnancy or the year after birth. So this is a psychiatric or mental illness that is within that direct period after pregnancy and birth. So this would include things like postpartum depression, postpartum psychosis, and other perinatal mood disorders. And this is a really important part of the discussion I'm going to have, and I will talk a bit about those disorders. But what I mean by maternal mental health is a much broader term, and I think this term really covers mental health as it pertains to the entire spectrum of motherhood and maternity and that entire experience. When I talk about maternal mental health, I really want to focus on the fact that this doesn't have to be within the year after birth, but it can extend 5 years, 10 years, 20 years, 30 years, decades after that initial birth experience, because research shows that these experiences really continue to impact women, especially women who might have experienced trauma during that time, which is common amongst our women who have schizophrenia and that we might be working with as patients. So something to know about maternal mental health, or a couple things to know. First, it is severely under-researched. It is actually very hard to find quality information about how this is impacting our patients. And a lot of that has to do with postpartum was not included in the very first DSM, and it really didn't get included till many, many years later. There are a couple of reasons for that, one of which was it was seen as something that only impacted women, so not necessarily a wide enough population to be focused on, especially during that time. And it also was seen to be something that wasn't critical. Women will get snap out of it. It will be, 6, 9 months and then it'll be gone. But nowadays we know that postpartum depression and psychosis can be very critical and can be very dangerous for both the mother and the child. And we have research that shows that it can lead to further issues and complications later on in life, which will impact the overall maternal mental health of that individual. In recent editions, it is now a specifier under major depressive disorder. So, this aspect of maternal mental health is definitely being talked about more, but a lot more can still be done. And something that is important to note is that there has been an increase in women with severe mental illness having children, because previously it was not very common for women with schizophrenia to have children, to get married, to be sexually active, to have those kind of long-standing relationships. A lot of that was because they were institutionalized, or the stigma was so great that they were unable to make those partnerships. However, now that we have better resources, we have better diagnostic tools, better medications, better community support, just a better understanding of mental illness. Women with schizophrenia and other severe mental illnesses are able to have children and have those long-standing relationships. But even though that amount is increasing, we're having more children with parents who have severe mental illness, there isn't an increase in the available resources and treatment programs for early intervention related to maternal mental health. So we know women with severe mental illness are having more children, but there isn't the same increase in the resources and services available to them out in the community. So I wanted to briefly talk about pregnancy and schizophrenia, and just what you should know about the way that they interact, because for many women, this will be the start of their experience with their maternal mental health. So the first thing to note is that pregnancy is often a trigger for the onset or worsening of schizophrenic symptoms. A big reason for this is, it's not a surprise, but pregnancy can be a very stressful event, not only on the physical body of a woman, but on the mental health as well. And it is well corroborated that schizophrenia is often triggered, the first onset at least, by a stressful event. Another thing to note is that the onset of schizophrenia in women is typically between 25 to 35 years old, which is a bit different than men, who are more around 18, 20 to 25. Although many women get diagnosed with schizophrenia before the age of 25, a lot of the research shows that that is the time range that it is most common. And something that also happens during that time range is pregnancy or the birth of the first child. So they're already, getting closer to their natural onset, and then the pregnancy can definitely be an event that will trigger the onset quicker, or make it more noticeable. Medication adherence is a primary concern with this population, and this, again, is not necessarily a surprise. Women might be concerned about medication side effects. They might be worried about how it might affect the baby. Doctors can be concerned about that too. Some doctors will try to adjust prescriptions when they find out that their patient is pregnant. The danger of that, though, and you know this if you've worked with in a psychiatric population, any med change comes with the risk that the patient will decompensate, or it won't be up to par with their needs. So when that's happening, when they're already hormonal and going through a lot of physical changes, it can be hard to notice whether they are decompensating, because sometimes these symptoms will overlap with just general symptoms of being pregnant and things that are more expected. And it can be a really dangerous situation. Women who have schizophrenia also are at higher risk for pregnancy complications, and this has a couple different reasons. A lot of them are behavioral, though, especially if they're decompensating and their medication regimen is not up to par. There can be delayed recognition of pregnancy, failure to recognize signs of labor, denial of pregnancy, attempting to prematurely self-induce, and many other behaviors similar to that, which can be dangerous for the mother and the child. And that kind of leads to the second part, which is they are more susceptible to hemorrhages and perinatal loss. There's not a lot known about the connection with hemorrhages in women with schizophrenia. A part of it could be just maybe missing warning signs or not seeking out help. as soon as they need it. And perinatal loss can happen in many different ways, but a lot of it can be induced by stress. And if they're not handling the pregnancy well because they aren't taking their medications, or their medication regimen is not up to par. And the last thing you should know is that overall, there is a lack of access to prenatal and perinatal health care for women with schizophrenia. The biggest part of this is that there's still such a stigma that many women and many parents with severe mental illness report not receiving help or going to these appointments out of fear that they will be judged or that their children will be taken away, they'll be deemed incompetent. There's a lot of fear surrounding that, and I'll talk more about that later in the presentation. I did want to spend some time talking about postpartum psychosis and depression, even though I am trying to focus on the broader spectrum, just because for many women, this is where it starts, and this is a significant part of their history that we should be considering. Postpartum depression can affect many women. It does not matter what their previous mental health status was. In fact, it affects 1 out of 7 women, and 50% of the cases start during pregnancy, not actually after birth. There is a misconception that postpartum depression will start 4 or 5 months after birth, but for many women, 50% of cases, it starts during pregnancy. And women who already experience maternal mental illness or mental illness in generally will have high rates of poor prenatal, perinatal, and antenatal health care. So this is just, even if it's not their first child or not necessarily the situation I was talking about previously where, the medication regimen might occur, it still can be tied with the stigma. There still is a hesitance sometimes to reach out for help later down in the road as well. And overall, women not even considering mental illness, 50% of women with postpartum depression receive help. So most women don't receive help in general. And for women who are predisposed to schizophrenia or another psychotic disorder, postpartum psychosis can trigger onset of schizophrenia and other psychotic disorders. So this is something that's really important because a trend that has been noticed is that women who are predisposed or might have a genetic or, a component that might end up being diagnosed as schizophrenia, their first psychotic break will occur near their first pregnancy because some of the things we talked about previously, it's around that same time frame, it's a stressful event. And if this then turns into postpartum psychosis, the treatment they will get, if they even get treatment, will be about postpartum psychosis, which is not a long-term treatment model. This misdiagnosis, and it can be hard to differentiate at this time, but it is a misdiagnosis, can lead to further complications down the road when the postpartum psychosis is not necessarily occurring anymore, but now they're just having the general and daily and chronic symptoms of their schizophrenia, and it's never been treated, never been properly diagnosed until years down the road when something else happens. And this is a trend you can see in many different cases if you look at when a patient was first diagnosed, and you kind of dig around those records. A lot of times you can see that there might have been something missed. And maybe if they had gotten early intervention, they wouldn't have decompensated to the point of having to be hospitalized further down the line or have recurrent hospitalizations throughout their adult life. One of the situations I mentioned in the very beginning of this presentation is pseudocyesis and delusions of pregnancy. So these are two conditions that cause a woman to think that she's pregnant when she is not. And this can be very common in the psychiatric population. And it's very fascinating. So pseudocyesis is the more rare condition, and that is derived from when the psychological desire to be pregnant creates a physiological response. And so the woman, and it can happen to men as well, will visibly present as pregnant. And they'll have symptoms like abdominal swelling, menstrual disturbance, spotting, breast tenderness, weight gain, and other changes that are very similar to pregnancy. But when an ultrasound or a blood test is done, there is no fetus. And this can last for an extended amount of time, way farther than 9 months in some cases. And it can be very difficult to work with patients on this because they can seem so pregnant on the exterior, and it can be hard to separate the delusions and this bodily response when doing reality testing. The more common one that many professionals have researched and reported on is just delusions of pregnancy. And that's the term for whenever a person just thinks they're pregnant and they're not. And it's not necessarily the same as pseudocyesis because you're not having the same physiological response that is creating the symptoms. Usually delusions of pregnancy happen when a symptom or symptoms occur coincidentally. And there's no actual correlative signs of pregnancy. So, for instance, a person might, their period might stop and they think that's because they're pregnant. And then because of the delusions they already have, because of their mental illness, they'll associate that symptom of the cessation of menstruation to pregnancy and latch onto that. Same thing with weight gain and other things. It can be very easy for them to correlate it with pregnancy. And then when that delusion gets stronger because of their mental illness and because of their past history, they'll really latch onto that idea and it'll create a condition of having delusions of pregnancy. I mentioned very briefly reality testing, and at the moment that is a big way that, and a primary way that professionals try to handle patients in these situations, because reality testing can, help them move through the delusion, and it can provide concrete proof that they're not pregnant, and it can be a really good way to help a patient see that they're not actually pregnant. So this can happen with blood tests, ultrasounds. However, the difficulty with this is patients with schizophrenia and other psychotic disorders can work around, even if they're given proof. It doesn't really target the root of the problem. It doesn't target the root of why they want to be pregnant. So it can be very ineffective for some patients. Research shows that there's a couple themes that are usually present in women who are experiencing pseudocyesis or delusions of pregnancy. One is medications. Some of the medications that our patients might be taking, especially the antipsychotics, can cause overproduction of prolactin, which is also caused during pregnancy, which can then make some symptoms appear that correlate with pregnancy, but they're not actually pregnant. Infertility is one that doesn't really need much explaining, but when a patient either finds out they're infertile or has fears that they're infertile or has any kind of anxiety around this issue, they might want to create a delusion of pregnancy, or they might go through pseudocyesis out of that desire. Companionship is probably the most common one and the one that you'll be most able to observe with a lot of these patients. Being in the hospital especially can be very isolating, and having a severe mental illness can be isolating for many people too. So if there's a patient who doesn't have a great family support outside the hospital, maybe never got the opportunity to have kids, or they did have kids but they don't have good relationships with them anymore, they feel lonely and they haven't been able to really form those close partnerships. The delusion of pregnancy or pseudocyesis can be a coping method to create a companionship that is only theirs and will fill that void that might be left by the fact that they don't have the supports that they really need. Menopause can also trigger pseudocyesis or delusions of pregnancy. This is kind of partly similar to infertility, but has a lot more to do with the hormonal changes go through the body, and I will talk about that more in the next slide. Trauma is a very significant root to this problem. If their birth experience, their childhood, their relationship with their parents, anything related to that had trauma involved, this could be a coping mechanism. Having a delusion of pregnancy, feeling like you're pregnant, can feel safe, it can feel secure, it can feel like you're making up for something that didn't go as well, and it can make up for some of that trauma. This can be really significant, and this would be something to know if you were noticing these kind of trauma experiences in a patient's history, and then they were having some motherhood related delusions. And finally, loss is one that can be really significant and doesn't also need much explaining. But if they have gone through perinatal loss or any kind of stillbirth, miscarriage, loss of a child when they're older, or loss of a relationship with a child, or even the lost opportunity to have children, this can all be very significant and cause them to start having delusions or hallucinations related to children. And just to clarify, although I am mentioning suicide and delusions of pregnancy, I do want to say that all of these things can also be the roots of other delusions related to motherhood. So when you have a patient who says, I have 20 kids and they don't have any, or even if they have only 3, but they report more kids than they actually have, or they make up stories about their children, or they think their children are visiting them, or they're hearing their children's voices, and things like that, that might just be related to motherhood, but are not actually related to being pregnant. So now I want to talk briefly about the hormonal changes that I just mentioned and just life transitions in general. So hormonal changes can trigger onset or worsen symptoms. So this means that when there's a hormonal change, whether that's through pregnancy or menopause, women are more vulnerable to psychotic episode, or having or decompensating, or just having a change in how their psychotic symptoms are presenting. Menopause has a lot of different implications. One of the primary things is that it causes lower estrogen levels, and there is research that shows there is a connection between estrogen and schizophrenia. It's not fully understood yet, but some research showed that a woman, so if you had 2 women that both were going to be diagnosed with schizophrenia at one point in their lives, the woman who naturally had a higher estrogen level in her body and naturally produced more estrogen would end up having a later onset than a woman who naturally produced less estrogen. Menopause is also a major life transition, a lot of changes to their body. They're going through, maybe changes to their social life, their changes to their identity. If it's a woman that ever wanted to have kids and never got a chance, menopause can cause feelings of regret or shame. It can make them feel bad about themselves. And even though for many women, menopause doesn't cause those feelings, a lot of times our female patients who are struggling with severe mental illness are very vulnerable to feeling this way. Loss doesn't always have to just include the loss of life. So past miscarriages, terminations, and maybe lost adult children are very important and should definitely be noted and definitely be regarded as critical information. But loss can also include the loss of opportunity to have children, custody arrangements, CPS involvement, estranged children, like things that aren't necessarily the loss of life. And I think custody is probably the most critical one that we will see as social workers working on discharge planning, especially, or just working with women who are having strained relationships with their families. Women with severe mental illness are just as likely to have children, but they are much higher risk of CPS involvement. Part of this is that they might have co-occurring factors such as substance abuse, domestic violence, and poverty, since women with severe mental illness are also especially vulnerable to those factors. But a lot of it has to do with stigma and the decompensation I previously talked about in scenarios where women do decompensate and are unable to take care of themselves and others, which may lead to custody loss, but might have been avoided if they had had earlier intervention. So this is a quote that I found really summarized what I'm talking about here from a case study that looked at women with schizophrenia who had lost custody, and then they were interviewed years after this event. So this quote says, I have several women whose children were taken away from them anywhere from 10 to 20 years ago, and they're still dealing with that loss and probably will for the rest of their lives. So here's a case example. Since this is in video format, if someone was watching this and would like to kind of work through it, just feel free to pause and talk it out or think about it. What information would you try to gather after learning this case? What is something that you still need to know? What might be your first course of action? And maybe what are the resources you would consider and the implications you would consider for this client? So now I just want to quickly go through the treatment implications. What do we do when we have patients going through this? So again, as I mentioned, majority of women with maternal mental illness do not receive any type of treatment. Research shows that early intervention works best, especially if it's integrated into a maternal environment or a labor delivery unit. The issue with that is it's not realistic for us to expect most patients have had that opportunity, especially if you're working with patients who might be older and not directly after the birth experience. So early intervention, unfortunately, isn't an expectation that's realistic for us to have. So what do we do with that? So even though we might not be able to provide early intervention for all of our female patients, we can still provide mother-focused treatment. What if we had a group that talked about custody loss? What if we had a group that talked about estranged relationships with children and allowed mothers to explore, or even a group for women that wanted to have children, never got to have the opportunity, and helping them find a way to put that mothering energy somewhere more productive than, dwelling on it or feeling depressed or resulting in, or anything that results in pseudocyesis or delusions of pregnancy. PSR groups are a great intervention. Psychosocial rehabilitation has been shown to be very effective with women with schizophrenia who are experiencing trauma or delusions associated with motherhood. And a lot of this has to do with the social interaction, can be very beneficial. Psychosocial rehabilitation programs, research shows that they really should just provide focuses on this if they're going to be for these motherhood experiences. Communication, parenting skills, relationship building, community resources and education, grief and loss, symptom management, and similar groups that really provide maybe a space for them to learn about the child welfare system, a space for them to talk about perinatal loss and things like that. See, not all of these groups have to be just open to women or mothers. They can be groups that are open to anyone, but they target skills that these women might need. So even if a program doesn't have mother-focused treatment groups available at the time, if this is a need of a mother, these are some ideas of groups that would be great to put them in just so they can build up skills that will make them more resilient to these delusions and this trauma. Research shows that having healthy relationships with children can lead to a patient's reduced stress, enhanced self-esteem, and improved medication adherence. So this really is in the best interest of our patients' recovery. A couple things to keep in mind for discharge with this population. Custody arrangements are probably the most important thing to consider with mothers, especially if this is a recent change and they have children under the age of 18. Things like proximity, visitations, accessibility. Are they getting placed in an apartment where they'd be able to have visitations? Are they in a close enough distance where they can visit their child without, if they don't have transportation? What might they need if they're working towards getting custody back? And things like that. Will they be able to potentially reunite with their children? It's going to be incredibly difficult. It's hard to find bedrooms that will be able to cater to all these things, especially if the patient does not have a lot of income or assets. But it is something that we should consider as their advocates and as the social workers helping them, be successful in the community. And then just general family relationships are important. Can the mother return to the family home? If she can't, will there be resentment against her family? Will she be resistant to leave? There's research that shows mothers who have recently experienced loss of custody or familial housing may self-sabotage. They may not want to experience this new normal. They might want things to go back to the way they were when they're not. It's scary to go out into the world when you have that kind of support cut off. So in conclusion, the things I really just want to have you all, whoever's listening to this, take away is that a patient's experience with motherhood is such an important part of our social history, and we as social workers should be considering how this might be impacting our female patients. Women with schizophrenia are more likely to have experienced perinatal loss, traumatic birth events, and custody loss. If we know that they're more likely to experience these things, it should be something that we're considering when we're providing them treatment. And lastly, even if the event occurred numerous years ago, research supports that mother-focused treatment can be beneficial for recovery. It doesn't matter if they're in their 50s, their 60s, it doesn't matter if this happened when they were in their teenager so long ago. It can still be impacting them, and it can be an underlying root that's causing a lot of other issues. And so that is my presentation. I'd love feedback on it, or if anyone has any comments, please let me know. I hope you enjoyed it, and I hope that this gives you something else to think about when considering how can we improve our mental health for women and how can we improve maternal mental health care.